group 19 want to present one of the interesting case, which is suspected acute polyradiculoneuritis in a local breed dog. So meet Jackie, 8 months old canine local breed dog. Is a female weighing 18 kilogram with a body condition score of 3 out of 5. It was managed outdoor with and fed with meat and dog food. The vaccination and deworming status is up to date. So from the history, on Monday, 1st November, owner noticed that Jackie cannot get up in the morning, and the next day, the owner brought Jackie to UVH. So from the physical examination, the temperature was normal, but slightly all the vital parameters are within normal limit. He appeared quiet, alert, and responsive with a pale pink mucous membrane with a CRT less than 2 seconds. He present with lateral recumbency with the generalized weakness. Notice enlarged bilateral popliteal lymph node. So neurological examination was done, and then he appeared alert and tetraparesis with a normal cranial nerve response, also absent of withdrawal reflex in all limbs. Notice delay sati and patellar reflex in hind limb, and also superficial and deep pain positive, and no hyperesthesia was noticed. So the localization from the neuroexam was generalized lower motor neuron.
So here's the problem list for Jackie. The first problem list is a tetraparesis, which is the generalized weakness. So for the differential diagnosis, spinal injury, the first one is spinal injury. Second one is a polyradiculoneuritis. Third one is a myasthenia gravis. And last one is a botulism. So the further plan is we do a complete blood count and serum biochemistry. Next is the radiograph. So the second problem list is the constipations. The differential diagnosis is the first one is the environmental factor. Second differential is due to the problem number 1. So the further plan is we need to monitor the replications. So the third problem list is inaptitude. The differential diagnosis is due to problem number 1. For the further plan, we need to phosphate. 2nd November. On the 2nd November, CBC and SPC, there's no significant findings. So for the radiograph was taken, there's also no significant finding. So we can rule out the spinal injury from the differential diagnosis. So we come up with a tentative diagnosis for this case as a suspected acute polyradiculoneuritis.
Moving on to the treatment plan for this case. So for the first problem list, which is tetraparesis, generalized weakness. So for the treatment is physiotherapy 5 times a day from day 1 to day 8 with indication to stimulate the movement of muscle and prevent muscle wasting. And change lying position 5 times a day from day 1 to day 8 to prevent positional atelectasis or pressure sore. And the third one is IV fluid lactated ranges solution from day 1 to day 8 as a maintenance fluid. Second problem is inaptitude, and the treatment will be complex 1 tab per hour SID from day 1 to day 8 as a vitamin supplement to stimulate appetite. Ranitidine 2 mg per kg with concentration of 25 mg per ml. IV TID from day 1 to day 5 as a H2 receptor antagonist to reduce gastric acid production, and force feeding day 1 to day 8 as restorative diet to provide energy. And last problem is constipation. We give 5 ml per hour BID from day defaulted and as osmotic laxative. So this is the progression for Jackie. This is the day one of presentation in VH. The first presentation, quiet, alert, and responsive.
And she was tetraparesis. Recompensating position.
On next, on the fourth day of hospitalization, Jackie started to use its volume and looked more brighter than previous days. Next, on the seventh day of hospitalization, Jackie started to use its volume to support her body weight, and she can start to sit but with help. The next day, Jackie can start to sit by her own without any help. On the same day, Jackie was decided to be discharged. So the prognosis for this case is good because throughout the week, there is improvement as Jackie started to be more active, brighter, and started to use its forelimb and hind limb. For the clarification, physiotherapy is needed twice daily. 15 any pressure sore. And also need to assist walking for Jackie. That's all for this case. Thank you.
Any question?
Guys, you mentioned that the vitals were normal upon presentation. Is a 200 beats per minute heart rate normal for an 18 kg dog, you think?
Yeah, the heart rate is high, tachycardic. It could be due to stress during handling the animal.
Okay. I have another question. When you did your neurological examination, you said your lesion localization is generalized lower motor neuron. Can you please explain to me?
The localization is generalized lower motor neuron because all of the forelimbs is tetraparesis and there's no reflexes. Right.
So how can you say generalized lower motor? Don't you need to identify which area you think? If it's tetraparesis, generalized lower motor neuron is very vague to me. Correct me if I'm wrong, Dr. Insan.
Well, normally that's what we do when we localize the lesion. I think in this case it was tetraplegia to begin with, right?
Yes, doctor.
Yeah, so use the right terminology.
Okay.
And then I would be okay if you use generalized lower motor neuron disease, or you could say that this is a neuromuscular localization.
Okay.
One question I have though is that, well, if you localize it to generalized lower motor neuron lesion, then why spinal injury is in differential diagnosis? And why do you take extra step to rule out spinal injury? And spinal injury is not a differential. It's a vague term.
For the spinal injury differential diagnosis is we put it as the differential diagnosis because we think to rule out the spinal injury that can cause the paralysis. But yeah, as doctor mentioned, it is cannot mentioned to make generalized lower motor neuron.
Yeah, so this is what annoys me. You had discussion with me, right, last week?
Yes, doctor.
Now, what did I say? If it doesn't fit with the localization or clinical signs, so do you still remember what did I say about differential?
Yes, doctor. So for the differential, we can put it as neuromuscular disease. For example, polyradiculoneuritis, myasthenia gravis, and botulism.
Sorry, you're not answering question. So if the clinical sign, if patient came with specific clinical sign, or even patient with neurological sign, you came up with specific localization, right? In this case, neuromuscular. And you know that spinal injury will not fit that. Why do you still put it as your differential? This is basic concept, guys.
Okay, sorry, doctor. We should not put spinal injury as the differential diagnosis in the first place.
Yeah, so it doesn't really fit. So I don't understand why you put it as your differential diagnosis and then go ahead and perform x-rays. It's just it's a kind of a waste of time and money. And I think I've mentioned this last week as well, that if it doesn't fit, then don't put it in your differential diagnosis.
Yes, doctor.
Okay? So sorry, you guys keep making the same mistake. And this is when it sort of like stray you somewhere else instead of like being in the right path. So for the client education, what is the mainstay of the treatment for this case?
Do you mean the specific treatment for this case?
Yeah.
Okay, for this case, polyradiculoneuritis, the specific treatment for this case is only physiotherapy. Yes, only physiotherapy is the specific treatment, and it will take like 2 to 6 months to complete recovery. And we can start to see improvement for like after 3 weeks of physiotherapy.
Right. So then usually cases like this, we would refer it for the patient for um physiotherapy. Okay.
Uh,
So the physiotherapy you do at home, it might not be enough.
for this, yes, doctor. Actually, for this case, after it's being discharged, this case is referred to post rehab for
Yeah, but this
more
is why
physiotherapy.
why didn't you say so in your client education? Why do you keep that information? That's the part I don't really understand.
Sorry, doctor.
Yeah, so that's the thing. So many missing information. I don't know whether you wanna like it's a secret that you keep from the rest of your classes.
Sorry, sorry, everyone.
You know. Okay, so the mainstay is physiotherapy. You must refer it out for physiotherapy, because whatever the massages and then your whatever flexing, extending the joint are not enough for this case. Okay. Right. You actually haven't come up with final diagnosis. You still have myasthenia gravis, polyradiculoneuritis, and botulinum. So how do you differentiate those, and what makes you so confident that this is polyradiculoneuritis?
If you want to differentiate polyradiculoneuritis and botulism, as they have same clinical sign, we can use based on the neurological examination for acute polyradiculoneuritis. Usually, the dog will have dysphonia, where botulism, dysphonia is actually the unable to and is medical term for disorders of the voice, and botulism doesn't have that clinical signs. And next, one of diagnostic workup that can be done is um, ENG, which is electroneurography, where we can see at the normal at the F wave, where botulism uh, will show normal F wave. For acute polyradiculoneuritis, will absent F wave. And for myasthenia gravis, usually a dog that presented with myasthenia gravis will have megaesophagus as the condition. And for this case also, the dog seems to be started to recover after physiotherapy without any intervention of medication. So we think that this case more to suspected acute polyradiculoneuritis.
Right. Well, keep going back to basic. Myasthenia gravis, they don't have this kind of typical clinical sign. It's more like a generalized weakness without the actual tetraplegia, even though it can happen. Megaesophagus, well, we've seen it in polyradiculoneuritis. It's not a hallmark anyway, and you can't really differentiate it from botulism. Okay, so the point is that in this case, it's very hard to reach final diagnosis. You need to have extra diagnostic step, which is not available in Malaysia. So I think you just have to say it is suspected, just based on the typical clinical signs and progression. There are some questions in the chat box if you want to answer that. Otherwise, that's all from me.
Thank you, Doctor.
So there is a question from Cindy Wong. Morning, guys. Sorry if I miss it. May I know what is the cause for polyradiculoneuritis in this case, and is there any predisposing or contributing factors? So I will answer the second question first from our reading. The predisposing factor is the dog that hunting for meat, raw meat, or exposure to raccoon, and are as higher factor to affect this disease. However, for this case, because from history from the owner, the dog consumed the meat, so we suspect the cause for this case is from the meat. Hope that answer your question.
Sorry, I kind of disagree. Again, it's very difficult to make such speculation. Majority of patient with acute polyradiculoneuritis has idiopathic trigger. Only small percentages might get it from raw chicken meat. I think due to Campylobacter species. But again, there are very little studies that reported those. Okay, just be careful.
Thank you, Doctor.
From Dr. Gaya's question, can acupuncture help for this case? There is no evidence or articles that can prove that acupuncture can help in this case or not. However, we still think that acupuncture might be help, and we think that there is no wrong to try. But physiotherapy is the main treatment. Thank you.
If there are no more questions, let's quickly move on to the next case, yeah, because today there's a number of cases that have to be presented.
So Doctor, sorry, I will answer very quick. Of recurrent in this case. So from my reading, relapse can occur, but it's rare to see relapsing on this case. Okay. We can move to the next case. Thank you, everyone.
So next, we are from rotation group 20. We would like to present a case of constipation in a Persian cat. So meet our patient. This is Bella, a feline 5 years old spayed female Persian, which managed outdoor with 4 other cats and fed with kibbles. So the history was on October 2021, Bella was brought to private vet with problem of right hind limb limping and prescribed with vitamin B, metacobalt, and then the cat recovered. So on the 1st November 2021, owner noticed right hind limb is still weak. So on the 5th November, she was presented to UVH. Upon physical examination, the TPR were within normal limit. So the cat was bright, alert, and responsive with pink mucous membrane with CRT less than 2 seconds and skin tan 2 seconds. So there was presence of hard feces palpated in the dorsal colon upon abdominal palpation. And this cat is having 5% dehydration. And we can see weight-bearing lameness of the right hind limb. So we come up with problem list of constipation with differential diagnosis of dehydration, dietary, and mechanical. So for dietary, it could be due to dietary indiscretion. And for mechanical, it could be due to GI tract obstruction, due to foreign body obstruction, or narrowing of the pelvic cavity, could possibly due to pelvic fracture or extramural obstruction. And for 5% dehydration, it could possibly due to inappetence, as the owner didn't take note of the appetite, as this is an outdoor cat. And the weight-bearing right hind limb lameness, it could be due to trauma, possibly due to fracture or luxation. So for the plan, to do abdominal radiograph, complete blood count and serum biochemistry, and also retention enema. So radiograph was done on the 5th November 2021, and the radiographic finding was presence of feces from ascending to descending colon, with radiographic diagnosis of fecal infection, and also presence of radiolucent line at the right coxofemoral, indicated by the red circle, with radiographic diagnosis of right coxofemoral fracture. CBC and serum biochemistry was done, and there's no significant finding for the CBC. For serum biochemistry, there was elevation in the total protein indicating hemoconcentration, could possibly due to hemoconcentration. So we update our problem list for constipation. We rule out mechanical cause of constipation, as we cannot see any GI tract obstruction or narrowing of the pelvic canal through the radiograph. And then for the weight-bearing right hind limb lameness, we suspect for right coxofemoral fracture.
As for the treatment for problem number 1, which is constipation, We gave retention enema BID, where we mix 7 ml of KY jelly, 7 ml of lactulose, and 7 ml of normal saline from day 1 to day 4 to soften the thecal material by increasing the osmotic pressure to cause a laxative effect. We also gave lactulose 1.5 ml per oz BID from day 1 to day 5 as an osmotic laxative. We also gave vitamin B complex 1 tab per oz BID from day 1 to day 5 as a vitamin supplement due to the ineffectiveness, and also papace 1 tab per oz BID from day 1 to day 5 as an anti-inflammatory for the bowel irritation due to constipation. And then we also give tramadol, 3 mg per kg, 0.19 ml, 16 ml subcutaneously, TID from day 1 to day 5 as an analgesic due to abdominal pain and discomfort that is caused by the constipation. And also metronidazole, 50 mg per kg, 8.1 ml slow IV BID from day 4 to day 6 as prophylactic antibiotic to prevent septicemia due to the constipation. And also problem number 2, which is the 5% hydration, we gave IV fluid to correct the hydration. And then problem number 3, weight-bearing right hind lameness, we opt for cage rest from day 1 to day 30 to allow callus formation. So this is the abdominal radiograph that was taken after the retention enema, and less radio-opaque structure can be observed at the colon as compared to the first day, indicating that the colon is not infected with feces. And then the cat defecate after the retention enema on day 1, and the retention enema was continued until day 4. And this image shows the latest update on the feces of Bella, which is a mixture of score 1 and score 2 feces. 9 of November. The prognosis is good as the cat started to defecate after we gave the retention enema. As for the client education, they need to monitor defecation for any signs of constipation and also high fiber diet. Also ensure that animals are well hydrated by providing fresh water at all time, and also allow cage rest for 1 month to allow callus formation to take place. Thank you. Is there any question?
Can you go back to your differential diagnosis list? Your problem list with differentials? Can you tell me what dietary indiscretion means? Simple question, guys. You don't have to Google this. What does dietary indiscretion mean? You've put it there, you should know, right?
Dietary indiscretion means animals feed on unusual items or changes in the feeding behavior, such as feeding on the garbage.
Yeah, so it's eating garbage or eating, just not being discreet about what it eats. So that means that it's not eating things it probably should. So can you tell me how that would cause a constipation? Dietary indiscretion causes diarrhea. It's not a differential for constipation. And one of the main things when we talk about constipation, if you go back and you do some reading, is environmental factors. That's huge in constipation. That's something that really needs to be looked into the household, whether there's any kind of thing that is causing some kind of stress, causing something that doesn't want this cat to go to the, to use the litter, etc. That's a huge part. And it's not even there in your differentials. Whenever we talk about constipation, it's not like, oh, okay, the poop came out, end of story. No. A lot of these cats have a recurrent constipation because you don't identify the underlying cause. So part of dealing with the constipation is always going back and trying to find out what is it that is causing this cat to be constipated.
Okay.
Was any extra history obtained from the owner?
No, doctor.
Has it recently been boarded somewhere? New cats adopted? Someone and
this is,
family member been away?
This is an
Yeah.
outdoor cat, so the owner didn't have much history and didn't monitoring this cat much.
Okay, so you need to find out are there many other stray cats in the neighborhood? Does it fight with those cats? You know, this is all information that's necessary because then a couple months down the road, again, the cat will come back with another episode. Okay? So that just remember that with constipation, that's a very, very important part is trying to identify the reason, the cause. And a lot of times it tends to be environmental. Yeah, I don't know, maybe it could have even been because of that weight bearing, right? It started off like that, you know, because obviously when they poop, they bear weight on their forelimbs, right? When they're in that position. So maybe it started from that. I don't know. It's painful, so it cannot sit in that position and therefore became constipated. But these things need to be looked into to try and identify the cause, okay?
All right, doctor. There's no more question. Can we move on to the next case?
Good morning to doctor and fellow friends. We are from rotation group 90. We'd like to present on the case fungal skin infection with suspected melanoma in the DSH Tom. Meet Oyen, 7-year-old castrated male, domestic short hair, weighing 6 kg. Vaccination and deworming were not up to date. It is managed indoor with multi-household cats fed with kibbles and red food. So from the history, few months ago, the cat mass at interdigital area of forelimb, private vet, and within a month there were a lot of nodules and mass ulcerated all over the body. Had generalized blackish pimples and mass all over the body. Sorry. A few months ago, the cat has had small mass at the interdigital area of forelimb. The mass removed at private vet, and within a month there were a lot of nodules and mass ulcerated all over the body. There is a generalized blackish pigmented nodules and mass all over the body. Went to private vet, but there is no improvement. A week before presentation to UVH on 1st November 2021, there is a generalized black mass nodule still persists with reddish ulcerated cornea of right eye was seen. And Ono also noticed blood oozing out from the right eye, and the cat is FALB positive. So from the physical examination, all the vital signs are within the normal range. The cat is quite alert, responsive, and there is a presence of generalized blackish masses all over the body. and also non-healing wound at the right distal forelimb with the presence of ulcerated cornea of right eye. And here is the nodules at the hind limb, both hind limb and also at the axillary region. And then there are also pigmented nodules found at the ear and then below the lips. And then this one is the swelling, moist, and ulcerated wound at the distal right forelimb. And here's the yellow with the red color discharge. And for the problem list, the first problem is a presence of generalized blackish pigmented masses all over the body. And the second problem is swelling of non-healing wound at the right paw or forelimb. So we came out with the differential diagnosis: neoplasia, melanoma, squamous cell carcinoma, cutaneous lymphoma, basal cell tumor, and could be fungal infection, sporotrichosis and cryptococcosis. And for further plan, CBC is to do CBC and serum biochemistry, thoracic radiograph, impression smear and cytology, excisional biopsy and histopathology, and also radiograph at the right forelimb. And the third problem list is ulcerated cornea of the right eye due to problem number 1 and also trauma due to scratching. And for further plan is to monitor discharges and give treatment, and also we wear e-collar. And here's the result for CBC and serum biochemistry. So there is a macrocytic normochromic marked regenerative anemia, leukocytosis, neutrophilia with left shift due to inflammation and infection, monocytosis due to chronic inflammation, and also reticulocytosis notice. And then for serum biochemistry, hyperkalemia is noticed, might be due to dehydration.
So the radiograph of the right forelimb and thorax was done. So for the right forelimb, there is also fat changes at the joint area with increased soft tissue opacity of the affected bone. And for the thoracic radiograph, there is no significant findings. And then for the impression smear cytology, we found there is a fungal hyphae. And there is a neutrophil with phagocytized bacteria, which suspected of the bacterial infections. So we did additional biopsy on a small nodules at the right hind limb and sent for histopathology. So the results still pending because it takes 2 weeks. And then for the updated problem list, for the problem of a presence of generalized blackish pigmented masses all over the body and swelling non-healing wound at the right paw or forelimbs. So we rule out sporotrichosis from the impression smear. And then we add a marked regenerative anemia, which is due to problem number 1 and 2. And then we need to monitor the PCV. So the tentative diagnosis of this case is fungal skin infection with suspected melanoma in a DSH Tom. So for the problem list of number 1 and number 2, we give tramadol subcutaneous for 1 day and then change to tablet for 4 days as analgesic. Then zinc 1 tab POSID for 3 days as anti-inflammatory. Augmentin BID for 3 days to treat bacterial infections. For the problem number 3, which is ulcerated cornea of the right eye, we give Nico eye drop, QID for 5 days during the daytime, and then we give chloramphenicol ointment SID for the 5 days, at night time as a topical antibiotic. And then for the mild regenerative anemia, we give ferrocite, BID for 3 days as iron supplement. So the prognosis of this case is guided to poor since so the metastatic rates of melanoma being reported is 30 to 75%, and this case is suspected already stage 4. There is evidence of spread of the cancer to the distant part of the body. For the current instructions, so first we need to monitor the progression of the tumor, the size, the consistency, the color, and the site. Second, follow the medication as prescribed, especially the antibiotics must finish. And then third is monitor bowel, appetite, and urination. And fourth is monitor cat's breathing because we suspect that it will could metastasize the lungs, will fight the breathing. And the fourth is avoid ulcerated eye scratching by wearing e-collar when not being supervised. So that's all from our case.
Sorry, if there is no question, can we move to another case?
Dr. Chan here. I'm looking at your impression smear. Are you sure this is impression smear or tape impression?
This is impression smear. We direct put the slide on the ulcerated skin.
Okay. So the area where your point as fungal hyphae, where is that fungal hyphae? These are hair, right? This is the hair shaft. I don't see any fungal hyphae over here. Where is it?
Sorry, doctor. Based on the cytology result, it's already labeled that this is fungal hyphae.
You mean this is
So
from our clinical pathologist?
yes.
That is definitely the hair shaft. I'm
Is it
not
on the
sure
right side?
whether I don't see any fungal hyphae there at all.
Oh yeah.
Could that be a mistake because they thought this is an impression smear? They didn't expect a hair being impressed on the slide. I'm not sure. I'm just
Ah,
Just my personal opinion.
it might be mistakenly thought.
Did you do a wood slap over the area? The ulcerated wound?
No, doctor. No, we didn't do it.
Is the cat still in the ward?
The cat is already discharged, doctor.
Oh, okay. All right. Thank you.
Thank you, doctor.
Can we move on to another case?
This is Dr. Gaia here. Can you please show me your differentials?
Yes, doctor.
Okay, I think I mean, you have your problem list number 1, nicely written number 1, number 2, but your differentials were all jumbled up for both the problems. And in this case, you are obviously, I think you need to prioritize what is the main problem or the complaint of the owner, and also the cat, is having. So I think swelling, or it's not just swelling, it's actually non-healing wound at the right paw would be the first different problem list on the problem list. And then you have a set of differentials for that, which mean the differentials may not be the same for the problem number 1, which is the generalized blackish pigmented masses, or I say nodules all over the body. Okay, because you don't have, you're not expecting generalized blackish pigmented nodules when you talk about squamous cell carcinoma or cutaneous lymphoma. So it doesn't fit those differentials. So you should try to separate them, because they might be 2 different problems. So as you can see, you've written there fungal, and you may not have that kind of lesions on the body for sporotrichosis, because the lesions on the body, they are all intact, with the skin intact. Okay, so and they are very flattened, and they're just blackish nodules, which is not typical for sporotrichosis. So I won't jumble up all the differentials just because you think problem number 1 and number 2 is related. Okay, so they are not, they are 2 separate problems.
Okay, doctor. Thank you for the correction and clarification. Thank you.
And the eye problem is also, is that the correct way of describing what the cat has? Can you show the eye again? The picture with the eye? Yeah, is it just superficial, corneal ulcer alone, or is there something beyond?
It is eye desmatocele. It's bulging, and it involves the deep layer of the cornea.
All right, so you don't just have corneal ulceration in this case. So you have written throughout your slides, saying that this cat only has corneal ulceration, which it is not correct lah. Yeah. So definitely the cornea is exposed. That means it's not intact anymore, but there is just something beyond than that. Okay, the whole eye is glaucomatous, and it's non-functional anymore already. So compared to the other eye, so and with discharges and all. Just wondering, was there any impression or cytology done on the eye discharges?
No, not yet, doctor. No.
No. And the cytology smear you showed Dr. Chanwei earlier, was it on the limb, on the leg, is the paw, right?
Yes.
Okay.
Thank you, doctor.
So in this case, why do you say it is melanoma suspected? Because the title highlights that.
Because it is a pigmented mass plus nodules.
I think we cannot really jump into conclusion and say that this is melanoma, and we have to be very careful and wait for the biopsy report first, yeah, to confirm, to know what exactly is happening in this cat. But what is the prognosis in general, and what can be done for this cat further?
The prognosis is poor to guarded because if it's in early stage, we can do surgical excision, but it have spread generally all over the body. So radiation therapy can be done or chemotherapy.
Radiation therapy where?
Doctor, there is no radiation therapy in Malaysia, but the nearest country is Thailand. Good. Only surgical removal of the apa tu, nodules can be done in Malaysia.
There's too many nodules to remove in this case. The whole body is affected. Okay, so I think we really need to talk to the owner about quality of life, and if you're really going to go in for palliative surgery, probably it's just the limb, yeah, the paw is very painful. It is rotting. There's significant. I mean, I'm sure there's a lot of pain. We need to think about how to address the paw and the eye. I think those are the two main things, which is main issues lah in this cat. The other nodules are very superficial on the whole body, and it is not hindering the cat's mobility, and it is not even painful when you palpate. So and the lungs and internal organs, there are no metastasis. I'm not sure, was any ultrasound done in this case? Abdomen ultrasound?
There's no there's no ultrasound done.
Okay. All right, so we have to wait for the biopsy report first. Huh?
Yes, doctor. Thank you, doctor. Can we move on to the next case?
All right, go ahead.
Good morning to all doctors and my fellow friends. So we would like to share about an ICU case on nasal oxygen catheter placement or nasal prongs in a labored breathing dog. So for introduction, what is nasal oxygen catheter, or we call it as nasal prongs? It is actually a nasal cannula with a small ball tube connected to one or two short prongs that supply oxygen directly to the patients. So what it is used for is actually to stabilize patients that needs oxygen. So this is Google, 7 years old canine mixed breed castrated male dog. He was kept indoor with 6 other dogs. Vaccination and deworming was up to date. On 7th of November, owner noticed that Google had labor bleeding at the midnight, and the next morning, the labor bleeding has been getting worse. So owner claimed that this problem had never happened before, and ABU was all normal. A few days before, there is no vomiting, diarrhea, and coughing. So Google was presented to UVH. Upon physical examinations, all TPR are in normal range. However, there is stertorous lung sounds observed and dyspnea. After Google was stabilized, thoracic radiogram was taken, from the red circle, there is increased soft tissue opacity at the craniomediastinal lungs, indicative of pleural effusion. At the caudal dorsal lung lobe, there is alveolar pattern with air bronchogram indicating pneumonia. From the DV view, alveolar pattern of the right middle lung lobe can be observed with the appearance of lobar signs indicating pneumonia.
So nasal oxygen catheter placement was done. The things to be prepared for this nasal oxygen catheter placement are, first is the oxygen tank, tubing adapter, nasal oxygen catheter or feeding tube, tape, suture material, 21 gauge needle, lidocaine 2% topical solution, oxygen humidifier and KYJ. First, before pressing the catheter, instill a few drops of lidocaine 2% topical solution in the patient nostril and elevate the nose for 2 minutes. Then, position the patient in standard recumbency and pre-measure the catheter from the nasal filtrum to the medial canthus of the eye and mark this point on the catheter using a piece of tape or marking the catheter. Then, for ease of placement, gently elevate the patient nose and apply a lubricant, which is KY jelly, to the tip of the catheter. Then insert dorsally into the nasal passage and direct it ventromedially. The nasal catheter is then inserted to the point where it was pre-measured and marked. Next, secure the catheter by suturing on the nose and skin and between the eyes. Connect the tubing adapter and extension tubing to the nasal oxygen catheter and connect the tubing to the oxygen source. To minimize mucous membrane irritation and drying, a humidifier is used to add moisture to the oxygen before delivering to the patient. That's all for us. Thank you. If there is no question, can we end the round?
Good morning, groups. I'm Chong. I want to ask when I do rotation in ICU unit, I see some oxygen chamber. They have the water, the one when you on, you can see bubble. And then some we don't need to attach that. That also can have oxygen. Is it the one with water, the bubble one, the humidifier that you mentioned in the previous slide? Or it's not actually, it's just the indicator yeah, this one, the
Yes, Bosco. This one is the humidifier, and it actually is usually used if they place the oxygen tube directly to the patient.
Oh, okay. Thank you. Thank you.
Okay. Thank you. We end the round. Doctor, if there is no question.
Yeah, okay. If there are no questions, you can end.
Thank you, Doctor. Thank you, everyone.
Thank you.